Hello and welcome to EPG Pathshala. My name is Dr. Winston Thomas. I am a radiologist working in KIMS Kottayam, Kerala. Today we will talk on the module on medical proton magnetic resonance spectroscopy and its clinical applications. Introduction. Proton MR spectroscopy is an excellent problem solving tool to conventional MRI, predominantly in the field of neuroimaging. The technique is also finding place in prostate, breast and liver imaging. This module deals with various clinical applications of proton MRS. Objectives: understanding the spectral metabolites, clinical application and interpretation of the spectrum, pitfalls in MRS. The common spectral metabolites in neuro-MRS. Metabolic information obtained by MRS can be helpful in diagnosis. NAA is only found in neurons and is a marker for neuronal density and viability. Phosphocreatine acts as a reservoir for the generation of ATP, which means that creatinine peaks serve as a marker for energy dependent systems. The choline peak consists of contributions from glycerophosphocholeins, phosphocholeins and choleins. Pathological changes in the membrane turnover or rapid cell division increase the relative size of the choline peak. Lactate is not normally seen in adult brain and its presence can be detected in cases of cerebral infarction, high grade malignancies or mitochondrial diseases. Myoinositol is a precursor of both phosphatidylinositol, the major inositol containing phospholipid, and of phosphatidylinositol 4,5-bisphosphonate. It also plays an important role in osmoregulation. Hunter's angle. Hunter's angle is a line that is formed by the metabolites in the MR spectroscopy, which is approximately 45 degrees in angle to the x axis. Metabolites myoinositol, choline, creatinine and N-acetyl aspartate NAA peaks are ascending in a normal spectrum. Any alteration in the slope of this line joining the peaks means the spectrum is abnormal. So, it is a rough guide to see if the spectrum is normal or not. Applications in neuroimaging. Let us start with pediatric leukodystrophies. Various neurological disorders in pediatric age groups can be attributed to inborn errors of metabolism, and MRS can provide specific information with regard to abnormal brain metabolites in such diseases. The following chart describes various pediatric leukodystrophies and the metabolites that are seen which are abnormal. For example, in Canavan's disease, we see that the NAA peaks, which are representative of neuronal elements, are way higher than other metabolite peaks. In phenylketonuria, the phenylalanine peak at 7.3 ppm is at a very high level. In diseases such as maple syrup urine disease, metabolites like the branch chain amino acids and oxo acids seen to resonate at 0.9 to 1 ppm are seen to be increased. Some metabolic disorders predominantly involving the basal ganglia like Meyer's disease show altered metabolic parameters as shown in the chart in the regions of the basal ganglia. Certain diseases like Alexander's disease show a peak in choline levels, lactate levels and myoinositol levels, while showing a decrease in NAA peaks in such diseases. Now, we will talk about some applications in the neonatal hypoxic ischemic encephalopathy. Significantly worse neurological outcomes have been demonstrated in neonates with increased level of lactate and a decreased ratio of NAA lactate creatine lactate and choline lactate levels. The presence of lactate is a marker for anaerobic metabolism and ischemia and could suggest mitochondrial diseases in the neonates. Application in brain tumors. Astrocytoma shows a relative reduction in NAA and creatinine while choline increases relative to the other metabolites. Glioblastoma multiforme may demonstrate a decrease in choline due to intratumoral necrosis. Abnormalities in the level of alanine, lactate and mobile lipids are also useful in determining the grade of a glioma. Metastasis shows similar spectra with mild differences in the pattern of lipid macromolecule signals. The detection of an increased peritumoral colon NAA ratio reflects tumor invasiveness and can be used to differentiate high grade glioma, which are invasive, from brain metastasis that exhibit a near normal spectrum in a peritumoral region. Other metabolites observed in the brain neoplasms include taurine in primitive neuroectodermal tumors or the PNET, alanine in meningiomas and glycine in high grade pediatric tumors. If biopsy is needed for diagnosis, the choline NAA ratio can help differentiate areas of solid tumor with the highest cell density from edema. Multivoxel maps can further help localize sites for biopsy from infiltrative brain lesions. Prognostication and treatment planning in oncology patients when surgery is not indicated, like in the case of diffuse brainstem gliomas and intramedullary tumors in spinal cord. A choline NAA peak amplitude ratio of at least 2.1 was found prognostic of unfavorable outcomes in pediatric diffuse pontine gliomas. MRS is useful in follow-up imaging after treatment, where the differentiation between tumor recurrence and radiation necrosis is often difficult in conventional MRI. Choline creat ratios of greater than 3 is associated with tumor progression, and a ratio of less than 2 suggests tumor necrosis. Now let us see the application in acute stroke and ischemia. Proton MR spectroscopy offers great potential after the hyperacute phase of stroke beyond 4.5 hours to assess several key characteristics of ischemic brain for prognostic purpose, such as a severity of ischemia and neuronal dysfunction and damage. Severely decreased NAA appears to be related to clinical stroke syndrome and more extensive infarction. A decrease in NAA on follow-up MRI spectroscopic data has been associated with ongoing ischemia and progressive infarction. Now let us discuss some role in neurodegenerative diseases like Alzheimer's, Parkinson's, Huntington's disease, amyotrophic lateral sclerosis and spinocerebellar ataxias are debilitating conditions that results in progressive neuronal degradation and death. The characteristic features of neurodegenerative diseases at MRI spectroscopy is a decrease in NAA typically localized to regions or region affected by the degenerative process. Now let us discuss the role of MRS in brain tumors. Astrocytomas show a relative reduction in NAA and creatinine while choline increases relative to the other metabolites. Glioblastoma multiforme may demonstrate a decrease in choline due to intratumoral necrosis. Abnormalities in the level of alanine, lactate and mobile lipids are also helpful in determining the grade of glioma. Metastases show a similar spectrum with mild differences in the pattern of lipid macromolecule signals. The detection of increased peritumoral choline NAA ratio reflects tumor invasiveness and can be used to differentiate high-grade gliomas from brain metastasis, which exhibit a near normal spectrum in the peritumoral region. Other metabolites observed in brain neoplasms include taurine in primitive neuroectodermal tumors, alanine in meningiomas, and glycine in high-grade pediatric tumors. If biopsy is required for diagnosis, the choline NAA ratio can help us differentiate areas of solid tumors with the highest cellular density from edema. Multi-voxel maps can further help localizing the site for biopsy from infiltrative brain lesions. Prognostication and treatment planning in oncology patients when surgery is not indicated, like in case of diffuse brainstem gliomas and intramedullary tumors in spinal cord. A choline NAA peak amplitude ratio of at least 2.1 was found prognostic of unfavorable outcome in pediatric diffuse pontine gliomas. MRS is a useful tool in follow-up imaging after treatment, where the differentiation between tumor recurrence and radiation necrosis is often difficult in conventional MRI. Choline creatinine ratio of greater than 3 is associated with tumor progression, and a ratio of less than 2 suggests tumor necrosis. Now let us look at some clinical scenarios where MRS can complement conventional MRI imaging to help us get better details of intracranial tumors. Here we have a case of lymphoma in the left posterior lobes of the brain. The images that are demonstrated are T2 diffusion weighted images and post contrast T1 weighted images. And MR spectroscopy obtained from the central part of the lesion show a very elevated choline peak, which represents increased cell turnover, and a drastically reduced NAA peak, which suggests very low neuronal activity. This is a case of a high grade glioma. We can see the lesion in the left frontal aspect of the brain, and here we see again a very elevated choline peak with a very low NAA peak, and hence we can shift our diagnosis more towards a neoplastic etiology as compared to a benign etiology like a tuberculoma or so. This is a case of a low grade glioma where we see that the choline peaks are high, but what we see here is that the NA peaks are not low enough, meaning that there are some neuronal activities and the choline peaks are high, but they are not high enough to call it a high grade glioma. Now let us talk about the role of MRS in acute stroke and ischemia. The proton MR spectroscopy offers great potential after the hyperacute phase of stroke, which is beyond 4.5 hours, to assess several key characteristics of ischemic brain for prognostic purposes, such as the severity of ischemia, neuronal dysfunction and damage. Severely decreased NAA appears to be related to clinical stroke syndrome and more extensive infarction. A decrease in NAA on follow-up MRI spectroscopy data has shown that is associated with ongoing ischemia and progressing infarction. Now let us see the role of MRS in neurodegenerative diseases. Alzheimer's disease, Parkinson's disease, Huntington's disease, amyotrophic lateral sclerosis and spinocerebellar ataxia are debilitating conditions that result in progressive neuronal degradation and death. The characteristic feature of neurodegenerative diseases at MR spectroscopy is a decrease in NAA, typically located to the region or regions affected by the degenerative process. The NAA levels reflect pathological severity. The NAA creat ratios or the NAA concentrations may be valuable prognostic indicators of disease progression either alone or in combination with volumetric measurements. Other observed data include decreased glutamine levels and an elevated choline levels and even elevated myoinositol levels. Now let us look at the role of MRS in differentiating infections in the brain. MR spectroscopy helps confirm the definitive diagnosis of pyogenic abscesses and provide information about the type of infective agent. Presence of succinate, acetate, alanine, leucine, isoleucine and valine are specific for pyogenic abscesses. Parasitic cysts contain succinate and acetate in the absence of branch chain amino acids. Tuberculous abscesses also show only lactate and lipid signals and are devoid of cytosolic amino acids. Tuberculous abscesses also show only lactate and lipid signals and is devoid of cytosolic amino acids. Now let us see a clinical scenario of a patient with a ring enhancing lesion in the right temporal lobe of the brain and a spectroscopic image that is obtained from the center of the lesion shows a very large lipid lactate peak. Now let us look at an image of a lesion in the prostate as demonstrated on the left side by a coronal T1 image, which shows a heterogeneous lesion in the pelvis mildly invading the peripheral soft tissue. On the right we see a spectroscopic focus that was obtained from the central part of the lesion. We see a voxel that shows a spectrum with an elevated choline peak suggestive of high cell turnover. What we also see is there is no evidence of a citrate peak to demonstrate any normal citrate or a normal prostatic tissue in this lesion. Whereas on the next image we see from an area of interest taken from the prostatic peripheral zone, we see a heterogeneous area in the peripheral zone. However, when spectroscopy was obtained in this region, we saw a very elevated citrate peak which suggests normal prostatic tissue, and then the choline peaks are however low on the left sided graph, and as compared to a graph that suggests a high choline peak on the right side, which could suggest an abnormal activity that is happening in the lesion. Application in breast imaging. The two main potential clinical applications of proton MR spectroscopy are as an adjunct to breast MRI imaging to improve specificity in differentiating benign from malignant lesions. The diagnostic value of proton MR spectroscopy in cancer is based on the detection of elevated levels of choline compounds, choline being a marker of active tumor growth. Proton MR spectroscopy is a very good supplement to MR breast imaging, which significantly increases the positive predictive value of biopsy as well as decrease the number of biopsy recommendations for benign lesions with non-mass enhancement. It has also applications to monitor or even predict response in treatments in patients undergoing neoadjuvant chemotherapy. It is observed that changes in choline levels could provide a biochemical marker of clinical response as soon as 24 hours after the first dose of doxorubicin based chemotherapy for locally aggressive advanced breast cancer. The change in choline levels within 24 hours was significantly different between responders and non-responders classified with the response evaluation criteria in solid tumors or the RECIST criteria, suggesting that the changes in choline within 24 hours after the first dose of drug was served can serve as an early indicator for predicting clinical outcomes, clinical responses to treatment for locally aggressive breast cancer. In the following image, we see the utility of MR spectroscopy in breast CA evaluation. Here is an image that shows the response of MRS over a period of time following a doxorubicin based chemotherapy for a patient with advanced breast cancer. The first image represents the pre-treatment image, 1 week pre-treatment image. We see a choline peak which is partially elevated. On day 1 post treatment, we see that the choline peak is still present and it shows a mild dip in activity. On day 42 and day 70, we see significant lowering of choline peaks over 42 and 70 days with almost a tiny speck of choline peak at the day 70. Now, this suggests that this tumor is responsive to chemotherapy, and this is well predicted by our modality, which is the MR spectroscopy. And this can help prognosticate such a case, and this is definitely a responding case of MRS, which this information could not have been obtained by a conventional MRI, which could only let us know on the size criteria and reduction in size and necrosis, whereas MRS can let us know on the specific chemical changes that occur in responders over the period of time when charted, when specifically charted over time. Repeat, help us analyze the biochemical changes when specifically charted over time. Now, let us look at the application in liver imaging. Firstly, evaluation of diffuse liver disease. Diffuse fatty liver is recognized as a characteristic feature of non-alcoholic fatty diseases, which often lead to necroinflammatory changes, also known as the non-alcoholic steatohepatitis, and even cirrhosis. This is also the third most common indication for liver transplantation. Fatty infiltration of liver may also be a result of chronic viral hepatitis caused by hepatitis C infections, drug hepatotoxic effects, and excessive alcohol consumption. Proton MR spectroscopy is effective for quantification of liver fat. The lipid triglyceride spectrum consists of multiple peaks representing CH3, CH2 at 1.3 ppm, CH2 and 2.2 ppm, and CH 5.3 ppm lipids. The total lipids are calculated as a percentage relative to water by summing the individual resonance peaks to obtain the total hepatic triglyceride peak area, then dividing this value by the sum of the total lipid and water peak areas. Now, let us look at the role in evaluation of focal liver disease. The use of liver MR spectroscopy for focal liver lesions is a challenge due to motion related artifacts and voxel size localization to small regions of interest. The principal metabolite that has been targeted is the focal liver disease is choline. Choline containing compounds occur at frequency of 3.2 ppm. 31 phosphorus MR spectroscopy allows differentiation of peaks of choline containing compounds into phosphodiesters, thought to represent a product of phospholipid breakdown, and phosphomonoesters, which is considered indicative of increased cell turnover within the tumors. Proton MR spectroscopy at 1.5 Tesla or to 7 Tesla is difficult. The dominant signal of choline containing compounds at 1 proton MR spectroscopy is attributed to the glycero-3 phosphocholine rather than the phosphodiesters or phosphomonoesters as in phosphorus MR spectroscopy. So, what is more important in focal liver lesions is to assess the choline through phosphorus MRS than proton MRS. So, phosphorus MRS is coming up in a big way to assess the choline levels in focal liver lesions as compared to proton MRS. Proton MRS, the role of proton MRS in focal liver lesions is less, it is difficult to obtain, it is quite challenging. So, we will not go into the depths of that in this module. The following image demonstrates a proton MRS picture to demonstrate fatty infiltration in, the following image represents the distribution of lipids in a proton MRS, and what we see here The following image represents the distribution of lipids in proton MRS to assess diffuse liver diseases. What we see in the graphs are a water peak which predominates along with CH2 peaks, CH2 lipid peaks and CH3 lipid peaks in the various graphs that you have seen here, and the newer trends in liver imaging such as infusion of hyperpolarized carbon-13 labeled substrates into the patient has the potential to allow fluxes in carbon-13 to be monitored through key metabolic biochemical pathways such as glycolysis and citric acid cycle and the fatty acid synthesis. Now let us look at the pitfalls in MRS. MRS is a challenging technique and should only be used when spectral data will provide clinical information that is not obtained by other imaging techniques. The technique is sensitive to magnetic field inhomogeneities and requires precise manual adjustment to ensure field uniformity. We have discussed this previously, it is called shimming. Artifacts can arise from dental implants, proximity to sinuses, inclusion of bone in the voxel and lipid signals arising from bone marrow. MRS data is noisier than a single voxel MRS. MRS is a very sensitive tool to motion. Now let us discuss the pitfalls in magnetic resonance spectroscopy in clinical imaging. MRS is a challenging technique and should only be used when spectral data will provide clinical information that is not obtained by other imaging techniques. It is a supplementary technique to conventional imaging. The technique is sensitive to magnetic field inhomogeneities and requires precise manual adjustment to ensure field uniformity. This is very crucial, and considerable amount of shimming is required before we start these studies. Artifacts can arise from dental implants, proximity to sinuses, inclusion of bone in the voxel and lipid signals arising from bone marrow. Let us summarize. Magnetic resonance spectroscopy or MRS detects metabolites such as N-acetyl aspartate, choline containing compounds, creatinine, phosphocreatinine and lactate. Measurements of metabolites, measurements of metabolic ratios provide comparable standardized diagnostic information. MRS can be valuable in diagnosis of leukodystrophies and mitochondrial disorders, providing prognostic information in neonatal hypoxia, ischemia, differentiating among brain tumors, staging tumors and identifying suitable biopsy sites in tumors, differentiating between tumor progression and radiation necrosis. MRS extends its role in detection and therapy monitoring of breast and prostatic malignancies, and we also discussed its role in liver malignancies where phosphorus MRS is coming up in a big way to assess focal liver lesions. This is the end of module 31. Thank you very much.